Now, what about muscarinic receptor antagonists? They have affinity but no efficacy and slow dissolution, and so they prevent the action of acetylcholine on muscarinic receptors. This is the character of antagonists. These drugs produce reversible blockade the actions of acetylcholine at muscarinic receptors without affecting synthesis, storage, or release of acetylcholine, and they act by competition. So if acetylcholine is increased, it will antagonize the reaction. They are classified into natural peloton alkaloids, which are derived from plant origin, include atropine and the hyoscine, and you have synthetic derivatives. Atropine is a natural peloton alkali. It is absorbed orally, metabolized in liver, distributed to all tissues, passes to CNS, excreted in urine partly unchanged. Rabbits are tolerant or resistant to atropine because they have atropinase enzyme. Pharmacological actions. On eye, mydriasis due to block of muscarinic receptors in constrictive papillary muscle. This is called passive mydriasis. So, light reflex will be lost. There is no reaction to light. There is no meiosis in response to light. They produce relaxation of ciliary muscle, which is called cycroplegia or paralysis of the muscle, and this will produce loss of accommodation for near vision. They decrease aqueous humor drainage, so increase intraocular pressure, so they should never be used in patients with glaucoma. And they decrease lacrimation. If atropine is applied locally in eye, its action will last for 7 to 10 days. It has a long duration if applied locally. Secretions. Atropine decreases all secretions, salivary, bronchial, gastric, and sweat secretion. Bronchi, bronchodilation, and dryness of bronchial secretions. Cardiovascular. If atropine is given in a small dose IV, it may produce initial bradycardia due to stimulation of cardiac inhibitor center, followed by tachycardia due to block of muscarinic receptors in heart. If it is given oral or large dose, it produces tachycardia. On blood vessels, it has no effect in therapeutic doses because most blood vessels have sympathetic supply. They have no parasympathetic supply. Toxic doses, especially in children, reduce cutaneous vasodilatation, especially in face, which is called atropine flush. Acetylcholine, when given a small dose, reduces hypotension by stimulating muscarinic receptors. This action could be prevented by atropine. We give atropine, it has no effect on blood pressure, but if we give acetylcholine in large dose after atropine, it will produce hypertension due to stimulation of nicotinic receptors. As mentioned before, which is called acetylcholine reversal by atropine. The effect on GIT decrease motility and secretions. Urinary, relax wall contract sphincter inducing urinary retention. CNS, stimulation of respiratory center and stimulation of cardiac inhibitor center, which is responsible for initial bradycardia, which can be observed when atropine is given in a small dose IV. Inhibits vomiting center and inhibits basal ganglia. So it could be used to prevent vomiting, and it could be used in treatment of Parkinson's disease. Large doses stimulate cortex, inducing excitation, hallucination, and coma. It has weak local analgesic action. Therapeutic use of atropine, pre-anesthetic medication. Before giving general inhalation anesthesia, atropine is given to decrease salivary and bronchial secretions and prevent bronchospasm, to antagonize respiratory center depressants, to protect heart from bradycardia induced by some general anesthetics, and to prevent vomiting. It is used in cholinergic poisoning, in parasympathetic poisoning to antagonize muscarinic effects, as in organophosphorus poisoning or phyostigmine toxicity. In treatment of severe bradycardia and heart block. In bronchial asthma, but its disadvantage is that secretions become more viscid, so we better use atropine. For fundus elimination, but of course its disadvantage is long duration, so graphicals are much better. In treatment of peptic ulcer, colics, and diarrhea. In nocturnal enuresis and urinary urgency to decrease frequency of micturition. Treatment of Parkinsonism. In motion sickness, but hyoscine is much better. And in excessive sweating, which is called hyperhidrosis, to decrease sweating. What about adverse effects? Dry mouth, blurred vision, and increased intraocular pressure, tachycardia, urinary retention, constipation, flushing, hyperthermia given in large dose, especially in children due to inhibition of sweating, CNS stimulation followed by depression. How can we treat atropine poisoning? Care of respiration and stomach gauche, cold fomentations to reduce hyperthermia or hyperpyrexia, physostigmine slowly intravenously to antagonize central and peripheral actions, or neostigmine to antagonize peripheral actions. Controlled convulsions by diazepam. Contraindications. Atropine is contraindicated in enlarged prostate in elderly males, prostatic hypertrophy, and in glaucoma, and of course in paradigms. What about hyoscine? It is a natural built-in alkaloid. It has shorter duration than atropine. It has potent effect. It's more potent on ion secretions, but less effect on heart. And CNS, it has a similar action to atropine, but it produces sedation and amnesia in therapeutic doses. It has no local analgesic action. It is used as atropine, but preferred in pre-anesthesia, especially in cardiac or thyrotoxic patients, because it has little effect on heart. It could be used also during labor, static with mepiridine to produce sedation and amnesia. It should be used with analgesic drug, because if it is used alone in presence of pain, it will produce excitation and delirium. It is used in motion sickness and to decrease vertigo in Meniere's disease. It could be used as antispasmodic in treatment of colics and in treatment of ulcer. It is contraindicated, of course, in glaucoma and urinary retention. What about synthetic atropine derivatives? We have Mydriatic group. They have shorter duration than atropine and hyoscine. They include homatropine, duration about 24 hours, and tropicamide, duration about 6 hours. They have shorter duration than atropine, They are used in inflammation of eye, iritis, and for fundus crenation, and they are contraindicated in glaucoma. We have antisecretory and spasmodic, for example, probenecilin and hyoscine butylbromide. They are used in peptic ulcer and colics. Muscarinic receptors are 3 types. M1 are responsible for gastric secretion. Byrenzepine and tilenzepine are selective M1 blockers, and they are preferred than atropine in peptic ulcers. Atropine, it causes bronchodilation without dryness. It is given by inhalation, and it is a quaternary ammonium compound, so it is preferred than atropine in bronchial asthma.